टॉपिक भी परकशन है, रेस्पिरेटरी सिस्टम का परकशन, जिसमें मैं बताऊंगा कि परकशन कैसे करना है. तो फर्स्ट ऑफ ऑल we will know that what we actually do in respiratory system examination. So there is a sequence of things. First we do the inspection, then we do the palpation, then we do the percussion, and in the end we do the auscultation. So first and foremost we will ask the patient if we can examine him or not. If he agrees that we can examine him, then we will move forward in our steps. So first the examination will be done, and after that the palpation will be done, and then will come the percussion. So there are some basic rules for doing percussion that everybody should know. So first and foremost rule is that you should wash your hands and your nails should be cut, and then you should start percussion. So the left hand of the examiner will be known as middle finger of the left hand will be known as the fleximeter, and the middle finger of the right hand will be known as the flexor. So what we do is we place the left hand firmly on the area where we have to percuss, and what we make sure is that none of the fingers are not in touch with the chest bone. We make sure that we are firmly putting all the fingers on the chest bone. And then what we will do is, with the help of our middle finger, the right hand, that is the percussing hand, with the flexor, we tap on the middle of the middle phalanx. We tap on the middle of the middle phalanx. And while tapping, we make sure that the movement is from our wrist. The movement should always be from our wrist, not from our elbow or not from our shoulders. And while percussing, we make sure that we do it twice on the same area or thrice. We should not make it more than 3 times because it may affect the lungs. And now we know about the basic rules of percussion. So now let's understand a little bit surface anatomy, so we actually understand that what we are doing. So to understand surface anatomy, we first get into the contact of suprascapular notch. It is here, suprascapular notch, and below the suprascapular notch is the angle of Louis. And at the angle of Louis, moving laterally, we will be getting the second rib, because the second rib attaches at the angle of Louis. And below the second rib, we will be having our second intercostal space. Below second intercostal space, we will be having our third rib, and below third rib, we will be having our third intercostal space, and so on. So now we understand the positioning of ribs. Now, while percussing, we should understand that what we are actually percussing. So if we are percussing, we should understand that what organ is lying in that particular side, because the probable chance of getting dullness in that area is the organ that we will be percussing. For example, in the right side, the probable dullness we will be getting is either ribs or the liver. So for that, we will be knowing about the position of liver. So liver is situated below the fifth rib on the anterior side. On the lateral wall, it is below 7th rib, and on posterior, it is below 9th rib. And after knowing the position of liver on the right side, we must know how we divide the lobes of lungs. Because while percussing, we must understand that what particular area of lung we are percussing, what particular lobe of lung we are percussing, if we want to understand the exact location of the lesion. So I will ask Pankaj to stand up. To find the margins or fissures of lungs, what we do is we first figure out where the medial border of scapula is. So the medial border of scapula is like this. This is the medial border of scapula. Then we ask the patient to raise his hand, and this medial border will become a surface landmark. So this medial border will go here and will join the coastal, will go along the coastal margin, and we will attach it with the 6th rib. And this whole mark from here to the 6th rib will become the oblique fissure. Now we will mark this, And then again on the fourth rep, we will start another line and we will intersect it with the same line that we were making while forming the oblique fissure, and that will be our horizontal fissure. So now we have divided our lung in 3 lobes, that is below the horizontal fissure, upper lobe, between the oblique and horizontal fissure, that is the middle lobe, and below the oblique fissure, that is the lower lobe. Now, what are the areas of percussion? The areas of percussion on the anterior chest wall are supraclavicular, clavicular and infraclavicular up to the 5th intercostal space. On the axillary side, it is from apex of axilla to the 7th intercostal space. On the posterior chest wall, it is suprascapular, scapular and infrascapular up to the 10th intercostal space and in between the scapula. So we have learned about what are the areas of percussion. Now we will understand how it actually percuss. So while percussing, there is this resonance sound that comes, that is the normal resonating sound of the lungs. Below the 5th intercostal space, below the 5th rib, we will get the dullness that will be due to the liver. On the left side, the probable cause of dullness will be either the fish-shaped heart that will be forming the superficial cardiac dullness, and there will be a drop space right here, which we will be forming by intersecting a perpendicular line from the sixth rib to the costal margin, and from the anterior wall of the axilla, we will be forming a perpendicular from the 9th rib, and then we will be merging the both perpendicular lines, and that particular area will be the drop space. In this drop space, we will be getting this panic sound, and this will be the area of abnormalities. Now, what are the tones that we hear? So normal tone will be resonating sound of the lung. If we get hyper resonating sound, that will be due to the consolidating emphysema. And if we get a dullness sound over a specific particular area, that will be due to the obstructive emphysema. If we get bilateral hypertonic sound, then it will hyper resonating sound, then that will be due to the whole emphysema of the lung. Now, one more thing that we notice while percussing is the tidal percussion that we do. Tidal percussion is basically for the proper movement of diaphragm. We percuss the diaphragm. So what happens is that we percuss the liver at the 5th intercostal space. We percuss the liver, and while percussing the liver, we get a dull sound. So we ask the patient to take deep breaths. When he will be taking deep breath, at the height of the deep breath, we will again percuss the liver. And we should get this dull sound at least 1 or 2 intercostal space below. If we are not getting the dull sound 1 to 2 intercostal space below, that means that lung is not inflating properly, or the diaphragm is not moving below properly. And the last thing is the shifting dullness. So in shifting dullness, what we do is, first we percuss the patient in sitting position. So we percuss the individual in sitting position, and we form a upper border of dullness. For example, if an individual will be having dullness over here, we will be finding a dullness over here in the sitting position. What will happen is, we will ask the patient to lie down. While lying down, we will again percuss the same area. And then what we will find is that the dullness will be no more at that exact position. It would shift a little below. That will be known as shifting dullness. Now, one more very important thing is the positioning while percussing. So, positioning of the individual can put his hand again on the head. While percussing the posterior chest wall, we will ask the patient to move slightly forward, and we will ask him to put his both hands on the anterior chest wall, and that will be the positioning of the patient. That is all. Thank you.